Good evening, Dr. Jitendra sir.
Yes, good
Namaskar.
evening, Dr. Sumita, Dr. Shruti, Dr. Ravi Shankar,
Good evening,
Kushal.
Jitendra.
Dr. Maya. Yes, madam. Glad to see you.
What's the temperature there? You seem to be in layers.
It's cold here. Yeah. So,
Anyhow, it is very cold in
sir.
Bangalore.
Namaskar.
So actually, I wanted to wear the coat.
Okay. Mhm.
It's very nice theme and very pertinent for pediatricians. And good you have a galaxy of experts. Nice to have part of it. Thank you very much.
Thank you for joining, sir, giving us your time in spite
It's
of your
pleasure
busy
of ours.
schedule. Dr. Nandish, good evening.
Namaste, madam. Good evening.
Good evening,
Kushal,
sir.
good
Good
evening.
Good evening, sir. Good evening.
Mahesh Kamte, sir. Namaste, sir. Ravi Shankar, sir.
Good evening, Nandesh. Good evening.
Yes, sir.
ಸರ್ ಇದು ಆಡಿಯೋ ಕೇಳಿಸ್ತಾ ಇದೆಯಲ್ಲ ಸರ್?
Yes, sir. Audible.
ಓಕೆ ಸರ್.
No, I told you, good evening, Nandesh.
So, is this a monthly activity or it is a twice monthly or how it goes?
Once in 2 weeks is what we're thinking, sir. So
Okay.
we've had the first session was conducted 2 weeks ago. We had a very interesting session on pediatric emergencies and OPD. We
Okay.
had quite an interesting set of discussion after the talk. So this is the second session now, sir.
Nice. I think it's good. This timing is also good. Pediatricians will be free, maybe. After with dinner, they may listen.
Dr. Geeta, good evening.
Good evening. Good evening.
मुझे क्या प्रॉब्लम है क्या? वो एक बार जॉब पूछने आया था तो टोपी डाल ले मुसलमान का क्या क्या कुछ सिंबल कर लेते, क्या क्या कुछ कर लेते आप। उसका साउंड क्यों निकालना है? साउंड नहीं, वो ब्लूटूथ डिस्कनेक्ट करना है।
Dr. Kalpana Datta ma'am, good evening.
Good evening,
Good to
everyone.
see you.
Yeah, I thought, it's not possible to join because it is HTTPS, not Zoom. Then I really suddenly found it is a Zoom.
Zoom. Yes.
Yeah. Nice to see you in the
Thank
fresh mood.
you. Same here. Good to see you.
I'll join by laptop.
Yeah, better. Maybe recovered after all the pedicon work, I think.
LIC से लेके SBI से लेके हमेशा उनके सामने आता है। ये बात समझ नहीं पाता है। हमें पार्टी को करना चाहिए कि उन्होंने जिस प्रकार के नेतृत्व छीन लिया, बची खुची सियासत, बची खुची इज्जत को मिट्टी में मिलाए
Somebody can actually mute the, participants.
मर्यादा
Yes, ma'am.
And maybe the video also,
उन्होंने जो किया है
have the audio and video on only of the panelists.
मगर झूठ कोई रहा नहीं।
Yes, ma'am.
जरा सा घटे बढ़े तो सच ना रहे और झूठ भी तो
Ravi Shankar, I think your iPhone.
ఫ్రైడే రోజు ఎడిట్ తీసుకురావాలి. అందులో ఉన్నాయి చూడు వరల్డ్ మ్యాప్ ఇండియా మ్యాప్ మనం తీసుకుంది వరల్డ్ మ్యాప్ ఇండియా
चीन इस आइलैंड पर दुनिया के जाने माने बड़े बड़े लोगों और जैसे एक्सटीन ने अपना करियर स्कूल टीचिंग से शुरू किया था, बाद में उसने हॉलीवुड में फाइनेंसिंग का काम किया और अमेरिका, यूरोप और मिडिल ईस्ट के बड़े बड़े लोगों से
So shall we start, Dr. Ravishankar?
Should we start, madam?
ರವಿಶಂಕರ್ ಹತ್ರ ಒಂದ್ಸಲ ಕೇಳಿ, ಅವ್ರು ಮ್ಯೂಟ್ ಆಗಿದ್ದಾರೆ, ಏನಂದ್ರು ಗೊತ್ತಾಗ್ಲಿಲ್ಲ.
Actually, I muted them, but still it is coming. I don't know why, how it is coming there.
Okay.
Okay, now it is not there.
Yeah.
Yeah, sure.
Can we start?
Yeah, better we start.
Yes,
I think already 7 minutes are over.
Yes. Kushal.
Yes. Good evening. Good evening. I am Dr. Kushal, Secretary of IAP Karnataka 2026. On behalf of IAP Karnataka and Samanvaya, I welcome all the participants. I welcome our speaker, Dr. Jitendra Sahu, our expert, Dr. Maya, our speaker, Dr. Mahesh and Dr. Yatish, along with our convener, Dr. Nandish, and our coordinator, Dr. Nandish, and convener, Dr. Sumita Nayak. And I also welcome our EB members, Dr. Priya Shivalli, Dr. Amal Raj from Tamil Nadu, and all the other senior faculties. And it's a great pleasure to invite you all for this session. And it is open to the Dr. Ravishankara to comment on the session.
Yeah, thank you, Kushal, and others who joined there. Kalpana ma'am and everybody all here, Palanetra, everybody here. And I'm very happy to invite my good friend, Dr. Mahesh Kamte, who is always helpful to me whenever I got a doubt in the neurology cases. Immediately he answers. And Yatisha from my hometown, he is also a very good one. And so these two people are there. So this is from the IAP Karnataka. We are doing this one. Just a brief introduction. It is an idea to introduce the best speakers of IAP Karnataka to the outside IAP people. So and also to interact with the outside IAP people to know what exactly their experience. With that intention, we started this one. So that's the reason I named this as the Samanvaya. So without taking much time, I request Dr. Kushal to take over. Thank you all.
Thank you, sir. Now I request Dr. Nandish, our coordinator, to comment.
Yeah, thank you, Secretary, sir. With respect to all the dignitaries present here, we welcome you all to the academic platform of IAP Karnataka. We are glad to have our chief guest, Dr. Jitendra Kumar Sahu sir here today, and our speakers, esteemed speakers, Dr. Mahesh Kamte sir, Yatish sir, and Maya Thomas, expert. We welcome you all, madam, and we are very glad for accepting our invitation to spread the academics among our members. I hope this will be a successful program, and your contribution will enrich the knowledge of all our members. Thank you all for coming to our platform, madam. Yes. Over
Thank you.
to you,
Thank you very
Kushal,
much.
sir.
Thank you. Thank you very much, sir. Now I would like to ask Dr. Sumita Nayak to introduce our chief guest, Dr. Jitendra Sahu.
Thank you, Dr. Kushal. Good evening and welcome to all our esteemed IAPians who are here this evening. A big thank you on behalf of the entire team to all our faculty and our chief guest, Dr. Jitendra Sahu, who has graciously accepted our invitation. Thank you to Maya ma'am for being our expert this evening, and of course our young faculty, Dr. Mahesh Kamte and Dr. Yatish. Thank you very much for accepting to do this session. It's an honor for me to introduce our chief guest for this evening, Dr. Jitendra Sahu, who is the professor of the Pediatric Neurology Unit at the PGI Chandigarh. Dr. Jitendra Sahu is also the chairperson of the Academy of Pediatric Neurologists of India. He is the founder member of the South Asia Infantile Spasms Research Group and the former vice chairperson of AOPN. He's the co-chair of the ILAE Telemedicine Task Force, and he has received many awards, including the National Science Award 2024 by the Honorable President of India, Dr. John Stober Pritchard Award 2024, and the Sheila Wallace Award 2016 by the International Child Neurology Association, the Bruce Schonberg International Neuroepidemiology Award for the year 2023 by the American Academy of Neurology, and the Bernard D'Souza Award by the Child Neurology Society. This is in brief. I'm sure if we go on talking about it, there'll be a lot to add for Dr. Jitendra Sahu. But sir, once again, we welcome you to this platform and request you to give your opening remarks. So Dr. Jitendra Sahu, sir.
Thank you very much for generous introduction, Dr. Sumita. And I thank all the board members of the IAP Karnataka chapter, Dr. Ravi Shankara, Dr. Shruti, Dr. Nandish, Dr. Kushal, Dr. Abhishek, and it's everyone. And it's a great pleasure to be here. And this is very excellent academic activity you are doing. My congratulations to you. And it's a great pleasure to see you have brought a very good galaxy of experts, Dr. Maya Thomas, Dr. Mahesh, Dr. Yatisha. And they are not only the experts in the Karnataka, they are best in the whole India. So, and you have chosen a very great topic. And the topic is just one message for my, this topic is about this headache. So pediatricians should make a clear distinction whether they are dealing with, it is the case of headache or this is a case of headache disorder, because your entire approach changes based on this distinction. Headache disorder is when there is no apparent etiology and it's the recurring phenomena because of that it is a disorder. And when it's just headache, it may be having underlying cause. If you treat, that may be corrected. So with this, I hand over to the organizers. Thank you very much.
Thank you very much, sir. Thank you very much. Now I would like to hand over the session to be conducted by Dr. Shruti.
Thank you, sir. Good evening, everyone. Thank you, Jitendra, sir. I think you've already tickled all our brains with just those 2-3 lines. And now all of us are very much interested in knowing about headache already. It is my great pleasure to introduce the expert for today's topic, Dr. Maya Thomas, although she needs no introduction. She is a senior professor and head of the Department of Pediatric Neurology. She is affiliated with Christian Medical College, Vellore. She is a recipient of multiple awards, and she has over nearly 90 publications. Her special areas of interest include neurometabolic disorders, drug-resistant epilepsy, neuroimmunology. She has established the Pediatric Neurology Services and CMC Vellore, that is the DM Pediatric Neurology course. Dr. Maya, ma'am, we welcome you. May I please request you to speak just 2 words, please?
Yeah, I'll stick to those 2 words. Thank you very much for inviting me to your forum. And I am really appreciative of the efforts that you all are taking to improve the academic culture within the IAP Karnataka. Thank you very much.
Thank you, ma'am. Thank you for those words. I would like to next introduce the speaker, a very renowned speaker for today's session, Dr. Mahesh Kamte, sir. He's the professor and head of the Department of Pediatric Neurology. He's associated with JN Medical College, that is Belgaum, Karnataka. His areas of interest include epilepsy, genetics of cerebral epilepsy, neurometabolic disorders, neuroimmunology, vitamin deficiency, and pediatric stroke. He has nearly over 125 publications, and he has also received the Best Young Scientist Award of KLE University in the year 2013. He's also the Secretary of AOC and India 2023 to 2025. We welcome you, Dr. Mahesh Kamte, sir.
Thank you.
On the same lines, I'd like to introduce another esteemed speaker for today's session. We have Dr. Yatish, sir. He is the Director and Consultant Pediatric Neurologist of Dhimahi Child Neurology and Development Center, that is in Shivamogga, Karnataka. He has done his pediatrics from Bellary and DNP from Amrita Institute of Medical Sciences. He has done a fellowship in pediatric neurology from Amrita Institute of Medical Sciences, Kochi. He has published multiple papers in various journals, and his areas of interest include neonatal neurology, neurocritical care, neurometabolic diseases, pediatric epilepsy, and neurodevelopmental disorders and neurorehabilitation. This is the introduction of our esteemed speakers. I think all of us are very excited to listen about headache. Without much delay, we will start our session for today. Over to you, to the expert and to the speakers.
I would also like to thank the organizers, especially IIP Karnataka, for giving this opportunity. It's a really very good initiative of having sessions on real cases and real solutions. Thank you. I'll share my presentation. The slide seen?
Yes, yes,
Yes,
yes.
sir,
Please
yes.
make it full screen. Yes, perfect.
Okay. So this will be the outline of talk. I'll give a brief introduction to headaches in children. Then we'll have cases followed by discussion. Then after every case, we can take comments by the experts. And at the end, we can have audience questions. As you all know, headaches in children are very common in children. They estimated to occur in about 75% of adolescents and 25% of younger children. 1/4 of adolescents suffer weekly headache, significant school absence and reduction in quality of life. This is frequently ignored by parents, teachers, and primary caregivers as a significant problem. Many clinicians in primary and secondary care find it difficult to treat. The impact on child's life is comparable to that of pediatric cancer, heart disease, or rheumatic disease. Such is the burden of headache in children. Childhood headaches can have impact not only on the family, on the patient, but on the entire family. Parents need to cope up with the alterations of their life when the child has a headache. Frequent and recurrent headaches can impact families with significant disability due to loss of school, work, and social functions. A proper diagnosis and management can lead to improved outcomes and quality of life of the child and the family. So we'll start with the first case. This is a 8-year-old boy who's studying in 3rd standard, and had headache for last 1 year. He's had more than 10 episodes of headache in the last 1 year. Out of these 10 episodes, at least 5 to 6 attacks have lasted for 20 to 30 minutes. And after this headache, he sleeps for about 1 to 2 hours. And after sleep, he feels better. He's not able to describe the type of pain. He just says that it hurts. He's not able to describe the quality of pain. He feels nauseating. However, there is no vomiting. During the headache, he prefers to lie down quietly with the windows closed. He's not able to play or sit in the class. He doesn't even like to watch TV during this time. The remaining 4 to 5 attacks have lasted for about 20 to 30 minutes. It is dull aching type without any nausea, vomiting, phono or photophobia. And during these 4 to 5 episodes, he's been able to continuous activities like play or watching TV. He was referred to ophthalmologist by the pediatrician, and the ophthalmic condition was normal. There was any refractory error. Parents are very worried because headache is going on for last 1 year, and they wanted a PET scan to be done to rule out any brain tumor. So this is the story. And whenever you have a child with headache, the first step we should always consider is to distinguish primary versus secondary headache. A detailed history and a thorough GPE, neurological and physical examination can do this job. What is primary and what is a secondary headache? It all depends on what happens in between the headache. If there is complete recovery between episodes of headache, we call it as primary headache. The study is absolutely fine between the episodes of headache. However, if there is any personality change or academic decline, visual difficulties, neurological symptoms, vomiting, faltering of growth, then we call it as secondary headache. So in secondary headache, in between headaches, that has got other complaints also. The most common primary headache disorders include the migraine and tension type headache, and we also have other rare headaches like trigeminal autonomic cephalgias. So secondary headaches can be due to altered intracranial pressure. It could be either raised ICP or low pressure headaches. It could be vascular, like due to subarachnoid hemorrhage or due to AVM rupture, dissection of the arteries or vasculitis. It could be due to drugs. When we use NSAIDs for more than 3 times in a week, it can cause analgesia-induced headache. It could be due to local cause like dental abscess, sinusitis, or a post-head injury. And sometimes it can be due to central or thalamic pain also. So if you take a proper headache history and do an examination, we can find the correct diagnosis and management. In a study was done by Dooley, wherein they took 150 cases. And in all 150 cases, they could reach the right diagnosis by taking a detailed history and examination. In another study by Abu Arafel in 2005, they studied 815 children with headache. And out of the 815, 3 had secondary headache. In all these 3, they could predict it from the history and examination. So you do a proper history and examination, we can differentiate primary from secondary headache, and there's no need for any investigations. How do you do that? You take a proper history, and we have this 7-item headache history. You look at the location of the headache. You look at the quality of headache, the intensity of headache, duration of headache, frequency, other effects of headache, and effect on the school performance and other aspects. So if you look at the pattern of headache with time, if child has got acute headaches lasting for a few hours to a few days, and then in between that is normal, then this is typical for a primary headache. That is migraine and tension type headache. Okay. If you have symptoms which is ongoing almost on a daily basis, we call it as chronic non-progressive headache. The symptoms start and it worsens with time. It called as chronic non-progressive headache. And due to acute insults like head trauma or infections, you have acute headache which can persist for a few days to a few weeks. So the course of the disease along with time can help you to guess the cause of headache. You need to look at the triggers for headache. For the headache disorder, any physical cause like trauma can trigger a onset of headache in a child. So psychological triggers like transition to secondary school, parental separation, parental fights can trigger a headache in a child. For individual attack, it could be due to sleep deprivation, starvation, exercise, dehydration, exposure to sunlight, due to travel like motion sickness or sleep change, school, stress at school, early school hours, and bullying at school can all trigger an individual attack of headache. In migraine, triggers are there in more than 2/3 of the patient and can have more than one trigger. It's important to pick up this trigger and address them when we treat the child. After the history, you should also take general pediatric history like the past history. Past history of infantile colic or benign paroxysmal vertigo, cyclical vomiting can indicate a possibility of migraine in a given child. Look at the growth and puberty. Look at history of use of drugs, especially analgesics. Using more than 3 analgesics per week can lead to analgesic abuse headache. Look at the lifestyle of the changes. Lifestyle is very important in any child with headache. Always look at the sleep, quality of sleep, and the amount and regularity of sleep. When does the child sleep? How many hours he sleeps? The sleep time, is it same or it changes with time? Looking at the eating and drinking habits. Does the child skip the breakfast? skipping of breakfast is an important trigger for headache. How much water does the child drink? Child should drink more water, especially in hot weather or when there is any physical activity in the school. Look at the screen time. How many hours child spends on the screen? Because exposure to screen can lead to sleep changes or sleep deprivation, and that can again trigger a headache. Exercise. Nature of exercise and is important. Over exercise can also cause headaches. And if you don't exercise, also it can lead to obesity and that can cause headaches. So the amount of exercise also has been important in the history. Then take a detailed psychosocial history, the emotional state of the child, education, attendance in school, and his school performance, social life, and the family history. It's important to note that headache and ADHD, almost 1/3 to half of patients with headaches can have associated ADHD, and 1/4 of patients can have associated learning disabilities. The ADHD and learning disability can lead to poor school performance, and that can add to the stress in the child, and that can present as headache to us. It's always important that when a child has got headache, you take a detailed school history, look at the notebooks, get the question papers, answer papers, look at how the child is performing this in the exams. You need to address this part also. Unless you address this part, there won't be relief of headache. Coming to examination, it's also very important. In a study done by Levis and Qureshi, they found that 18% of 150 children with headache attending the emergency department had serious underlying pathology, and all could be identified by neurological signs. Okay, so if you do a detailed examination, you can pick up all the serious causes for headache. Brain tumor headaches are associated with neurological findings in 85% within 8 weeks of onset of headache, and in virtually all cases by 24 hours. So if you do a detailed examination, or if you do repeated examination, you can pick up all the serious causes for headache. Then you do a detailed examination, take a look at anthropometry, height, weight, BMI, head circumference, and pubertal status. Look at the heart rate and blood pressure. High blood pressure can present as headaches. Do a detailed skin, scalp, face, neck, and oral examination, and followed by a detailed neurological examination. In the skin, look for neurocutaneous markers. Okay. In the scalp, look for tenderness. Tenderness can point towards allodynia, which is seen in tension of headache or migraine, and in sinusitis also, we can have a tenderness in the sinus points. In the neck, look for range of movement and tenderness of neck muscles. Oral, look for the temporomandibular joints. After this, do a detailed CNS examination. In the eyes, look for visual acuity, eye movement. Lateral rectus palsy can indicate raised ICT. Look for visual field. Visual field constriction can indicate, again, papilledema and raised ICT. Look for nystagmus and fundus for papilledema. Cranial nerve, sixth nerve is very important because it can indicate raised ICT. Also look for other cranial palsy, which can indicate a brainstem involvement and then also suggest a secondary cause. Detailed examination of the CNS is very important. Look for signs of ataxia and focal motor deficits. And don't forget to look for the meningeal signs, which can be a feature of meningitis. If you're not able to reach a complete conclusion, or if assessment incomplete, do a follow-up. Call this child again after about 2 weeks or 4 weeks, and again reassess this child. Now, after you've done this, whether it is a primary or secondary headache, you should try to see the cause of primary. If there's any secondary cause, then it is a primary headache. In primary headache, try to see what type of primary headache it is. Is it migraine, or is it tension type headache, or is it a trigeminal autonomic cephalalgia? That is also called as cluster headache, Sunar Sun. However, this TAC is very rare in children. They're usually seen in adults or in adults in Europe. Only 1% of all headache in children can be due to TAC. So basically, migraine and TTS are the most common type of primary headache. You can use the ICHD criteria for diagnosing these conditions. Coming back to our case did not have any features of secondary headache. So we thought of primary headache. And because this child had headache, which was severe grade, associated with which made the baby to go to sleep also, and sleep-related headache, and there was associated nausea, migraine was a possibility here. So we look at the ICHD criteria for migraine. This is the International Classification of Headache Disorders, classification for migraine without aura. So the criteria says that there should be at least 5 headache that last for 2 to 72 hours, plus at least 2 of the following, that is unilateral location, pulsatile quality, moderate or severe intensity, aggravation by walking or similar routine activity. At least one of these following 4, nausea and or vomiting, phonophobia, and photophobia. So if you come back to our child Our child had headache for about 20 to 30 minutes, and then child used to sleep for about 1 to 2 hours. So does it qualify for this 2 hours? It's important to note that headache in children can be shorter. It may not reach the criteria given of 2. And in children, it's important to note that the child sleeps after the headache. The sleep duration is also taken as a part of the headache duration. So a child used to have headache for about half an hour and used to sleep for about 2 hours. So total duration is around 2.5 hours. So it does qualify for this criteria. Our child had a dull aching headache. He could not localize to any one side. It's important to note that in children, more than 50% headache are bilateral, and it can be either frontal or frontotemporal location. The pulsatile quality. Many children are not able to describe the exact type of pain. So the pulsatile quality is not a must in children. Moderate to severe intensity. We say the headache is moderate to severe. The child is not able to play or carry on its activity. So the child refuses to sit in the class, is not able to watch TV. It means that it is a moderate to severe intensity. And the child starts going to a dark place, starts lying down in the bed. It indicates that there is phonophobia or phonophobia and photophobia. So we need to infer from the behavior of the child. Nausea, vomiting, phonophobia, and photophobia. Vomiting is rare. Nausea is very common. Almost 80% of children have nausea. Vomiting may be seen around 80%. Some of them can also have a pallor also. And it's important to note that usually when the child sleeps, the sleep relieves the headache in a migraine patient. So we look at this ICG criteria. The disease or disorder is not the event. Migraine is a disease that has headache as a symptom. Not all headaches need to meet the ICD-3 criteria. Like in our case also, out of the 10 or 12 headaches child had, only 5 to 6 met the criteria of migraine. The remaining 4 to 5 did not meet the criteria of migraine. So we can still label the child as having migraine because child had at least 5 to 6 attacks fulfilling the criteria of migraine. So all headaches in a child with migraine need not fulfill the criteria for migraine. Even if they fulfill only 5 to 6 headaches fulfill the criteria, we can give the level of migraine. They just need enough data to initialize the diagnosis. Sleep is considered a part of duration in children. The child has headache for 10-15 minutes, and he sleeps for 2 to 3 hours, then you can consider sleep as a part of the duration of headache. The step 3 is, if you have any secondary cause, you should do investigations. But for a primary headache, there is no need for any investigation like neuroimaging, CSF examination, or EEG. Like in this child, the history is quite typical for migraine or fitting with the criteria for migraine. So there is no need for any MRI or EEG. Coming to step 4, that is management. Management of migraine has got 3 prongs. The foundation or the most important part of management is the lifestyle modification. As we told, migraine can be precipitated by lack of sleep, dehydration, starvation, stress in the schools, exposure to sunlight, constipation. So all these factors have to be tackled. So lifestyle forms a very important part of treatment of migraine. If you don't get any drugs also is okay, but you should always advise lifestyle modification. It is a long-lasting solution for migraine. Then we have preventative strategies and acute management. Acute episode of migraine can be tackled by giving NSAIDs like ibuprofen, paracetamol, and we can use triptans also. So triptans are effective if given within the first 1 to 2 hours, and you can always combine these drugs also. You can combine NSAID with triptan. This child has got more frequent headaches. They say at least 1 headache per week or more than 4 headaches in a month. Then we can use preventive drugs. And this we have options of using anti-convulsant drug like topiramate or valproate. You can use antihypertensives like propranolol. Then you can use antidepressant like amitriptyline. It all depends upon the degree of disability imposed by the patient's headache. So this was a case of migraine without aura. I would like to discuss 2 short cases. This is a 3-year-old boy who used to have 5 to 6 episodes of sudden onset severe pain around the left eye. Okay, it used to last for only for about 1 to 3 minutes and used to associate with redness and tearing from the same eye. That is very agitated and profusely cry during the episode. After about 1 to 3 minutes, he used to be totally fine. These episodes happened once in a week to once in 15 days. Just very brief 1 to 2 minutes of severe pain in the left side of the head with the pain in the left eye. Another case, this is a 8-year-old girl who used to have again similar complaints. Okay. Very severe pain lasting for only 1 to 2 minutes. And during this pain, she's in immense pain and she's not able to relax at all. Okay. And this happened multiple times in a day. Okay. So this can fit into a type of primary headache called as primary stabbing headache. So it can happen any side. It's not side locked like in cluster headaches. They are very short, usually last for a few seconds up to 10 minutes, but very severe headache. They're unprovoked. They can be single or can happen in clusters. Comorbid, normally not associated with other features like restricted to the trigeminal duration. It's important to note that they respond to indomethacin. Unlike our routine migraine which responds to ibuprofen, this responds beautifully to indomethacin. And if you want to prevent recurrent attacks, you can use a drug like verapamil. Very rare, but I've seen around 3 to 4 cases. I just thought it's nice to describe this type of headache also. So I'd like to take comments from Maya ma'am. Maya ma'am?
Thank you, Mahesh, for those really, interesting cases. So migraine with aura and migraine without aura, as you rightly mentioned, the international classification for headache disorders, they have laid down a diagnostic criteria, but we should remember that these criteria are guidelines to establish a diagnosis of migraine. And as was rightly mentioned, it all depends on a witness account and a clear history to determine the type of the headache and the behavior of the child during the episode. Would you like to mention what are the common aura that that one can experience? Though usually in children we don't get this the classic history of aura, but usually the common diagnosis that we make is a migraine without aura. But would you like to mention what are the typical aura that one could experience?
Yes, ma'am. So the aura injury, as you told, is very rare, ma'am. Only around 10% of children can have migraine with aura. So common auras include visual auras, wherein you have black and white zigzag lines or black and white circles, which can vary in size. So a colorful aura typically happens in epilepsy, whereas black and white auras are more in favor of migraine. So these auras will evolve over a period of 5 minutes to 60 minutes, and usually are followed by headache within 60 minutes onset of this aura. The other aura include brainstorm aura, which was previously called a baseline migraine. Sometimes you can have even weakness on one side also, that is called hemiparetic migraine. And sometimes you can also have a dysphagia along with headache, or before headache, children can have abnormal speech. And the rare last one is a retinal migraine. It's again a rare aura what we see in children with migraine aura.
Yeah, absolutely. So they can be, motor, sensory, psychic, all these phenomena, visual, all these phenomena can happen. But the commonest thing that we see is a migraine without aura. And most commonly, we, as was mentioned, though investigation is not really required if we take a proper history, but most often to allay the anxiety of the family, you end up with a neuroimaging, especially if they come with recurrent episodes. Would you like to mention what are the indications for neuroimaging in a child who presents with a headache?
Yes, ma'am. Basically, ma'am, actually, to avoid this neuroimaging, I tend to examine the child take a detailed history and do a detailed examination. At least 5-10 minutes in examining the child, properly from top to bottom, do detailed examination. We can reassure the parents that we have done a thorough examination and there's no abnormality in our physical or neurological examination. And then we can assure the parents that nothing is wrong with the child. Most likely it's a primary headache and we can avoid imaging. But as I told, sometimes when you have on an examination any signs of neurological involvement, like any signs of raised ICT, like a lateral stress palsy, papillary edema, any focal deficit, any cranial palsy, it can be an indicator for any parenchymal involvement, and that time you should do an imaging. If you have any systemic signs or any history of change in personality, growth faltering, which can again indicate a brain tumor, there we need to do a imaging. Sometimes the history of fever, meningeal signs, then there can be a possibility of meningitis. There we can do a imaging with the contrast to look for any meningeal enhancement, and that can guide towards further lumbar puncture in these cases.
Yeah, so these are the, what we call the red flags that one needs to be alerted for when you see a child with headaches. But often, if it's a true migraine, usually they respond to the, the treatment that Mahesh has actually just mentioned. Lifestyle modification, the acute treatment, which is usually, just plain acetaminophen and ibuprofen, they do respond. If they still keep coming back with headaches, then you need to suspect something else. Is there any other psychosocial factor which is involved either in the school, at home? Those are the things that, and then you may need to get the involvement of maybe a counselor, a child psychologist, child psychiatrist in the picture. But true migraines actually do respond to these three pillars of treatment.
Thank you.
Yeah.
Now I'd like to request Yatish to present his case. Yatish?
Yes, sir. So, good evening all. I thank the organizers of K. Samanvaya for inviting me to discuss few cases about the headache. After listening to Dr. Mahesh Kamtesar about the approach and management of the primary headache, so let me present a case. So I request all the audience to interact actively. You can type your questions in the chat so that we'll be able to be having a more of interactive in nature. So here we're having a 16-year-old female child with a normal birth and normal development without any comorbid conditions. She presented with on and off headaches in 6 months, which was generalized in nature, lasting for 2 to 4 hours, moderate to severe in nature, more in the afternoon, and it peaks by evening and it decreases with rest. There was no photophobia or phonophobia, raised ICP, or any focal-neurological deficits. So, any thoughts here at this stage? So, it is a chronic recurrent headache, probably of a migraine in nature, in an adolescent female. Next slide. So, on examination, she was conscious, her blood pressure was normal, with weight of 76 kg and height of 162 centimeter, and BMI was 29 kg per meter square. There was no neurological deficits, and fundus examination was normal. So, keeping in a point that adolescent female with chronic recurrent headache, so and it decreases with rest lasting for hours. So we initially thought of diagnosis of a migraine without aura, and she was started on topiramate with other symptomatic treatment. But even after after 1.5 months of topiramate, her headache was persisting. In addition to the headache, she developed transient visual disturbances with dizziness. At this time, the fundus examination showed disc edema. There was no any focal neurological deficits or any double vision. So, with this in mind, because she had a disc edema, so we thought of ruling out the secondary causes, and we did MRI brain. So MRI brain was normal. So because the MRI brain was normal and there was a features of raised ICP, to document the CSF pressures, we did a lumbar puncture. It showed the CSF opening pressure of 340 mm of water with normal analysis. So with this, we came to a conclusion of, next slide, sir. So, probably you are dealing with the idiopathic intracranial hypertension. So idiopathic intracranial hypertension may be a primary type or a secondary type. So to rule out the secondary causes, we did MR venogram, which was normal. So endocrine evaluation, including hypothyroid evaluation, hypoparathyroid, and serum cortisol were normal. ANA screening was negative, and visual field was normal. So in addition to topiramate, which was started initially topiramate was started keeping in mind that she was an adolescent and adolescent and a overweight female, because topiramate will also reduce the headache frequency in migraine, and it will also helps to reduce the weight. So we continue the topiramate, and topiramate helps in IH because it works on carbonic anhydrase inhibitor, so that it will decrease the CSF production. So we added on furosemide. With this, our headache was still persisting. So in addition to that, we added on amitriptyline. In addition to that, we have counseled for lifestyle changes to reduce her weight, and she was under constant follow-up with a visual field monitoring. Around 4 to 6 months, her headache frequencies are decreased. There was no any progression or in the worsening of the visual acuity. So, next slide. So to summarize, the diagnostic criteria for idiopathic intracranial hypertension are: there should be a features of raised intracranial pressure with a normal neurological examination, except maybe fast localizing signs like abducent palsy, with a preserved consciousness, and a normal neuroimaging, including MR venogram. And CSF should show a elevated pressure, and analysis should be normal. Pressure should be more than 25 centimeter of water, and with the exclusion of the secondary causes. So with this criteria, we will be come to a diagnosis of a idiopathic intracranial hypertension. So the treatment approach of idiopathic intracranial hypertension consists of the, so next slide. So the main goal of management of the idiopathic intracranial hypertension is to preserve the optic nerve functions, because if the persistent rise of intracranial pressure will with papilledema, it will damage the optic nerve, so it will reduce the visual acuity. So we have to preserve the visual function and manage the intracranial pressures. So we need to monitor the patient visual acuity, color vision, and more importantly, visual field. So visual field, they will have a blind spot. Gradually, there will be enlargement of the blind spot. And color vision will be not usually affected unless they develop the other complications like optic atrophy. In addition to the monitoring of the visual acuity, we need to counsel for if they are overweight for the weight reductions. And if they are taking any exogenous or medications which can produce us the IH, like nalidixic acid, quinolones, or any other medications, if possible, we have to try to avoid that. And we have to control the raised ICP with a carbonic anhydrase inhibitors like acetazolamide. And both acetazolamide and topiramate work almost equally. And if there is no visual loss, if the patient having a progressive visual loss, here there is a controversy about trial of a steroids. Still, if there is no worsening, we can try a surgical measures. Like most commonly, we can do either optic nerve penetrations or a CSF diversion procedures like lumboperitoneal shunts or the ventriculoperitoneal shunts. So this is about the first case. It was a, so here what the point we have to remember is an adolescent overweight female presenting initially as a chronic recurrent headache, which was not responding to the migraine. So and she developed a new symptoms, that is with the visual disturbances. At that time, when we did a re-evaluation, we were able to pick up the optic edema, and from that we will be able to diagnose of IAH. So, Madam, any comments?
Thank you, Dr. Yatisha, for highlighting this very important clinical entity, especially when a child, adolescent, a child who's obese comes with a chronic progressive headache. one should keep this in mind. And an ophthalmic evaluation whenever a child presents with headache is very important, whether it is tension type or migraine type or IIH, because it will reveal a lot of information. When we do a neuroimaging, like you said, basically when you say normal neuroimaging, we are basically ruling out, things like tumors or any other vasculopathies. But IIH itself has few findings on MRI, and the things that we need to look for is, one is what we call a perioptic halo, a very prominent perioptic halo. They can have what is called scleral buckling, and they can also have what is called like a partial empty cella. So these are things that we could look for in the neuroimaging. And also if you do an MRV, because that's again another test that we need to do when somebody presents with like what we call a chronic progressive headache. The MRV in IIH also will show features of what we call either a hyperplasia or hypoplastic transverse sinus, or a kinking of the transverse sinus. So that's also another finding that we could watch out for in IIH. And generally they do respond to treatment. And the main thing that one needs to watch out for is, the severe thing that can happen with IIH is loss of vision. So initially they start off with transient visual obscurations, which is due to a sudden because of the raised ICP, because of the pressure on the retinal artery. They can have what is called these transient visual obscurations, which are very brief, lasting for a few seconds. And that is actually very frightening for the child. And then they can actually go on to develop complete loss of vision. So that is something which we should prevent, and that is through medications. And if there is impending visual loss, then of course the ophthalmologists need to come in, and for the urgent treatment, that optic nerve fenestration is what one could advise. So this child actually responded to topiramate furosemide combination.
Yes, madam. It's a medical line. Right.
Yeah. So usually they respond, and actually acetazolamide alone can also be given, because it's one of the, because topiramate is a weak carbonic anhydrase inhibitor, whereas acetazolamide is a powerful carbonic anhydrase inhibitor. And acetazolamide itself can actually cause a lot of anorexia, and helps in a reduction of weight as well.
Thank you, madam.
Now I think we can
Yeah,
move
you
to
can
the
proceed.
yes, ma'am. Next case.
You want to go on to the next? Yeah, sure.
Yes, ma'am. This is a 9-year-old boy. Daily headaches for last 1 month. He's absolutely fine till 1 month back, and since 1 month he's been having daily headaches. It's a constant dull aching headache, bifrontal location, and that was worse in the morning. Even if usually this is migraine, sleep will relieve the headache here, but here, despite having a good sleep, the headache was worse in the morning. There is no associated nausea, vomiting. Photophobia was present, but no phonophobia. And as I mentioned, least sleep did not relieve headache here. There is some relief with the paracetamol, which you should take. Fever, cough, cold now when he presents to us. However, the history of running nose and mild fever a month back for a few days before the onset of these headaches. So with this picture, this is a child who has been having headache which is not characterized. So it's a dull aching headache. It is there almost throughout the day, and sleep did not relieve this headache. Photophobia was present, but no phonophobia. And there is some partial response to paracetamol, and he's been having almost daily headaches. So it is not fitting the criteria of migraine. So does it fit into a tension type headache? To label the child as having tension type headache, ICHD 3 criteria says that there should be at least 10 or more headache lasting for 30 minutes to 7 days with more than 2 of the following. That is pressing or tightening quality, bilateral location, mild or moderate pain not interfering with daily activities, pain not aggravated by routine physical activity, and both of the following, that is no nausea or vomiting, no photophobia or phonophobia, or only one is present. So As I mentioned, tension headache is a featureless headache. It's not like a typical pulsatile or a throbbing headache what you get in migraine. Compared with migraine, there is less precise characterization, less severe pain and less incapacitating, and there are fewer associated symptoms. So depending upon the frequency, if less than 1 per month, we call it as infrequent episodic TTH. Frequent episodic is 1 to 14 days per month, and it is called as chronic TTH when there are more than 15 days in a month child has this type of headache. So our child had almost constant headache for the last 1 month, and there was a preceding fever with cough and cold. So this child was not fitting the criteria for TTH. So to look for secondary headache, we should look at these red flags, what Mayam was discussing. What is the red flags in a case of headache? Worsening headache with fever, sudden onset headache that reaches maximum intensity within 10 minutes, typical for subarachnoid hemorrhage, new onset neurological deficit or cognitive dysfunction, declining school performance or deficit like hemiparesis or a facial palsy or a cranial palsy, change in personality, impaired level of consciousness, recent, that is typically within the past 3 months in the history of any head trauma, headache triggered by cough or valsalva, like trying to breathe out with the nose and mouth blocked or sneezed, headache triggered by exercise, orthostatic headache, that is headache that changes its posture, symptoms suggestive of giant cell arthritis, symptoms and signs of acute narrow-angle glaucoma, and substantial change in the characteristic of this headache. In these red flags are there, we should always investigate this child or at least refer. There are some postural maneuvers which can give a clue to the headache. If getting up relieves the headache, okay, and coughing and straining exacerbates it, it indicates a raised intracranial pressure. Okay, so when the child gets up in the morning, the child will be better there. And if child coughs and strains, the headache will worsen. If lying down relieves the headache, it can indicate a low pressure headache or sinusitis. So coming to our case, our child has been having daily headache in the last 1 month. So can it fit into this entity called as new daily persistent headache? There's an entity called as new daily persistent headache, wherein the criteria include the daily persistent headache within 3 minutes of onset and should last for at least 3 months. It is pressing or tightening quality, bilateral location, mild to moderate pain not interfering with the daily activities, pain not aggravated by routine physical activity, and both of the following, that is no nausea or vomiting, no photophobia or phonophobia, only one is present, not attributed to another disorder. So in our child, this child is in a headache for last 1 month, daily headache is there, but it's not for more than 3 months. So it did not fill the criteria for daily persistent headache. So we went ahead with the detailed examination. In our case, this child started with the history of fever and running nose for 3 days. So we examined ENT in detail. So child had both frontal and maxillary sinuses which were tender. Throat was congestion and there was a postnasal drip. There was nose block also, and the Muller sign was positive. So this was suggestive of sinusitis as a cause of headache in this child. So when the child presented to us, child did not have any cough, cold, but child had a preceding URI, and then that led to sinusitis, and sinusitis was presenting as a headache. We saw a lot of these cases in the month of December and January. I saw at least 10 to 12 cases in my OPD with this complaint. What is Muller sign? Muller sign, in this sign, we ask the child to pinch the nose and blow against the closed nose for 5 seconds to increase the sinus pressure and then cough. It creates a positive pressure in the sinuses followed by rapid decompression. If sinus disease is present, there will be pain over the involved sinuses. So do not do this test during an ongoing headache. And it's important to note that ICP can also, RAGE ICP can be a false positive in this Muller sign. So our child had a Muller sign. So we diagnosed it as sinusitis. We gave a course of antibiotics and paracetamol with breathing exercise for this child. And our child improved over a period of 2 weeks. And after 2 weeks, the child was free of headache. So it was a case of sinusitis presented as almost a daily, dull-aching, characterless headache. Very common during winter season. So before we label it as migraine or TTH, we should always rule out common causes like the sinusitis as a cause of headache in children. Any comments, ma'am, on this case? Or any experience?
Yeah, facial pain is also a very common, any facial pain, occipital pain. These are also all, are all put in this basket of headaches. So it is important to note the location of the this, craniofacial pain. So all that can give us a clue to, what is a possible, even for that matter, even a dental caries or any toothache can also, be referred to as a headache. So
Headaches.
there are multiple, yeah. So a toothache or a sinusitis or maybe even an otitis media can, present as a headache in smaller children. And of course, if there is associated respiratory illness, then, and also a good examination of the oral cavity also is important. And look for sinus tenderness in these sort of, we may need to rule out easily treatable causes of craniofacial pain.
Thank you, ma'am. Yatish. Okay.
You want to go
Yatish.
ahead with
Sorry,
this case?
sorry. So, sure, madam. So he is a 17-year-old born to consanguineous married couples. He had a neonatal seizure secondary to hypoglycemia with delayed development, and he had occipital lobe epilepsy from 6 months of age. And seizures are well controlled on oxcarbazepine and valproic acid. And currently is in the 9th standard and is having a difficulty in scholastic performance. So next slide. So this was in his initial imaging, which is showing the occipital lobe flare hyperintensities, suggestive of a occipital lobe gliosis. So next slide. So since he presented, it was almost now his follow-up from long time. Since last 18 months, he was complaining of on and off headache, which was again, it was a generalized moderate to severe. It was associated with the phonophobia. And an examination, there was no any positive examination findings except is having underweight and is having a short stature. With this, with any thought of maybe having a functional headache or an ophthalmological cause for the headache or other types of primary headaches, even epileptic headache were also considered. So functional, because he's already having a scholastic performance poor without a functional headache and it was concealed, there was no any ophthalmological causes and EEG didn't showed any increase in the interictal discharges. So he was started on, in considering the tension type of headache, he was started on amitriptyline. So next slide, sir. But he was on amitriptyline for quite a long time. But his headache was not showing any improvement. He used to have a relief for certain period of time. Then again, he used to come back for recurrence of headache. In last year, May, it came with a sudden worsening of headache with a water sensorium. So we thought of maybe in addition to this primary disease, he may be having a secondary cause of headache, maybe a tumor or a bleed or other causes. So we went ahead and we also considered the possibility of a non-convulsive seizures. So the neuroimaging showed in T1 weighted images showed a isointense lesion in the cellular region. Next slide, sir. And hyperintense lesion in the T2 images without any contrast changes. So next slide. Next. So these are the images of this child showing the cystic cellular mass. So with this, and it was compressing on the optic nerve. So on blood investigation, he had hyponatremia. So with this, we thought of maybe a cellular mass, maybe a Reticular cyst or a cystic pituitary adenomas. So, and hormonal assay showed almost all hormones are in the lower range. In a cortisol was low and free T4 was low and even FSH, LH, all hormones are low. It was again multiple pituitary hormone deficiency. and optal examination showed incomplete left homonymous MENOPR. Next slide, sir. So he was referred for a neurosurgery. So by that time, because they were reluctant to go for a neurosurgery opinion, and even after the opinion, they were reluctant to undergo for the decompressive procedure. So finally, they underwent the procedure in the last December. At that time, the repeat imaging was showing the apoplexy features. I didn't have those images. So they did a endoscopic endonasal transsphenoidal approach decompression of the cyst. So here what I want to highlight is, even though he is having the primary disease, so he developed this other secondary cause for the headache in the form of the mass. So the pediatric brain tumors are the, as all of you, is the second most common cause of malignancies in children, and they can present in almost all age groups, and supratentorial are common in the infancy, and in the 2 to 12 years infratentorial lesions. They can have varying presentations. The outcome depends upon histopathology and molecular diagnosis, and the treatment approach is a combination of the chemotherapy, radiotherapy, and the surgical, depending upon the location of the systems. Next, I will quickly go to the another case. So this is another case. He is an 8-year-old boy with a normal birth, normal development, no any comorbid conditions. He presented with a sudden onset of headache and vomiting with altered sensorium of 4 days duration. An examination, he had a papilledema, and there were the reflexes were brisk with the extensor plantar. So here only 4 days duration of acute onset severe headache without any history of trauma or a fever. So with this, we thought consider possibility of the intracranial bleed or any vasculitis or tumor, and we went ahead with the imaging. For our surprise, next slide. So next slide. So our surprise, the imaging showed the features of the hydrocephalus, even including the dilatation of the fourth ventricle. It was a case of fourth ventricle outflow obstruction, and there was no any contrast enhancement, and he almost with a impending herniation. So this child underwent ventricular peritoneal shunt on the same day. So now the child underwent a patient in the 2020, that is during the Corona time. Till now, she is doing fine. So this case represented where there is a static case, maybe child maybe had some arrested hydrocephalus, and sudden worsening of the hydrocephalus may be secondary to the membranous blockage of the foramen of Magendie. Madam, any comments?
Yeah, so both these cases tell us that in the background of some form of headache, there is a new pattern to the headache. So as mentioned in the red flags, whenever there is a change in the pattern of headache, again that is a red flag, and that child probably requires further investigations. For example, the child with the occipital lobe gliosis, occipital epilepsy itself can present with headache, where they can have the child itself, meaning may not, unless you ask, they will not tell of visual hallucinations. They can have visual hallucinations, and they will actually, if you ask them, they will actually give you history of either a simple visual hallucinations in the form of bright lights or colors or rainbows, to they can have even complex visual hallucinations in the form of seeing images. And these can, be followed by intense headache. So in the background of this occipital epilepsy, the child has presented with a new kind of headache. So whenever there is a change in the type of headache, again, it's a red flag and will require a further investigation. And obviously, the child was diagnosed to have a pituitary tumor, and with some other had a pituitary apoplexy as well,
Yes, ma'am.
causing severe acute headache. The second child was a case of hydrocephalus, a communicating hydrocephalus. The CSF was normal in that case?
Yes, ma'am. CSF was normal.
Okay. So did the child have any other, neurocutaneous markers or anything?
No, madam.
Okay, right. So the chronic progressive headache and presenting with raised ICP
Acute worsening.
and acute worsening. Yeah.
Thank you.
Yeah.
So to summarize, childhood headaches are not uncommon. Most headaches have got a good outcome. Though we discussed 3 secondary cases, primary headache is the most common in our OPD. History is the key to the diagnosis, and thorough clinical examination is very important. If you do a thorough, detailed clinical examination, you can reassure the parents that you are examining the child in detail. Nothing is seriously wrong with the child, and you can even get away without doing imaging in most of the cases. Many parents are simply seeking reassurance that their child doesn't have a brain tumor. So we need to spell it out to the parents that our examination does not indicate a possibility of any brain tumor, so not to worry. And then most of them need a change in the lifestyle, which is a very important part of management of primary headaches, followed by acute interventions. And those cases of frequent headaches, we can do preventive measures also. Thank you.
I can see some questions in the chat box. Do we have time for that?
Yes, madam, you can answer, madam.
Yeah, I think one of them is how do we measure CSF pressures? Do we usually measure it? So usually when we do a lumbar puncture for the commonest indication for lumbar puncture is of course when anybody presents with an acute encephalitis syndrome is when we do a CSF. Ideally, you should measure opening pressure, but often I don't think in any regular meningitis, encephalitis case, we do measure the opening pressure. But of course, for IIH, it is one of the diagnostic criteria to have the CSF opening pressure being done. So the simple thing that we all do, I do not know if the others also follow the same thing, but what we usually do is we do the regular lumbar puncture with the the spinal needle, LP needle, and then we connect. Normally, we just connect a regular IV set to the needle, and then we should allow the child. Somebody should be there to extend the leg and make sure that the needle is in place, and then you lift the IV set up and allow the CSF to gradually ascend. And once it stops ascending, then you take the level of the CSF from the level of the needle and straight up. So that is how you get the CSF opening pressure and you measure it in millimeters of a CSF. So that's what, and the usual you can get up to 20. Anything up beyond 20 is millimeters is abnormal. Do anybody? The only problem with this this technique is it requires a lot of CSF, but this is very practical, and you can use a CSF actually for the analysis, so that you're not draining out a lot of CSF. That is one technique that we usually use, very practical. The next question is: anybody else follows any other methods? Yeah. Yes. So the next is what is the other next question?
Shruti will read out the questions. Shruti, can you please help,
Shruti,
ma'am?
okay, you're the
Yes, ma'am.
Shruti, please help, ma'am.
Yes, ma'am. Ma'am, here we wanted to know can idiopathic intracranial hypertension recur despite treatment? Any inputs on that?
Yeah, so as was mentioned, one of the important causes is lifestyle, that is obesity. So if you don't address those issues, it can persist, and it can actually give rise to chronic papilledema, and it can cause visual disturbances. So definitely that's why it's important to address the triggers and the endocrine, the lifestyle, all that has to be addressed. So otherwise it can actually become like a chronic papilledema and they can have visual disturbances.
We also have one more question. What is the role of neuroimaging in sinusitis?
Sinusitis is a clinical diagnosis, so we need not do imaging. But if the headache persists, when you do MRI brain, we can look at the sinuses, and if you have collection in the sinuses, that can indicate sinusitis. So for persistent sinusitis, we need not do imaging. But if it is persistent, then definitely we can do. When we do MRI brain, sinuses are already covered in that.
We have another question here. How common is it for refractory errors to cause headache in children?
Refractory errors, we usually get an oscillation for most cases of headache. However, they're very rare to present as headache. They come with more of eye pain. And it's typically whenever they're trying to focus on reading the books or when they're trying to focus on the blackboard, they get headaches that time. So refractory presenting as headaches is very rare, I would say. But it's a routine that we get oscillation for done for initial headache, refractory and even for papilledema.
Thank you, sir. Is there any role of butterbur, feverfew, COQ10, magnesium? Any role of these in treatment of headache?
These data mainly come from the adult literature. So in children, there was a very nice randomized trial done in US called the CHAMP trial. Then they try to look at the efficacy of 3 drugs in prevention of migraine. They used amitriptyline, topiramate, and a placebo in prevention of migraine headache. And they found that in placebo, there is a better response than compared to drugs like amitriptyline and topiramate. So in children, the placebo response is very high, unlike adults. So most of the children respond to lifestyle modifications. And even just a visit to the clinic, counseling, lifestyle measures will be of great help than using any of these drugs. So coenzyme Q, magnesium, feverfew have been used in adults, and there are some studies in children also. But I feel if we can do a proper lifestyle intervention, we can help most of the children. And most of them do not need any of these drugs.
Yes. Thank you, sir. They also want to know about the causes of occipital headache.
Occipital headache, again, migraine itself can, migraine without aura, migraine with aura can present with the occipital headache. Then any form of occipital epilepsy due to various causes like occipital gliosis, then or any kind of focal cortical dysplasia involving the occipital lobe can have occipital headache. We should remember when there is acute onset of occipital headache, it's called occipitonuchal pain. It can present in children who present with vertebral artery dissections. They can present typically with occipitonuchal pain. Yeah, these are the usual causes of even tension type headaches can present with severe kind of again back pain over the back of the head. Yeah.
I think someone has asked about the role of B12 in migraine, but I'm guessing that what Mahesh sir just spoke about, it's pretty much the same answer for the same. I think our last one more question that we have is someone.
Any role of B12 in the migraine?
B12, vitamin B2 is used. So B2 is used. B2, riboflavin, magnesium, and coenzyme Q have been used. B12, I don't think so.
Cyproheptadine.
Cyproheptadine is usually used in cyclical vomiting and BPV. Sir. In migraine, because of sedation effect and weight gain, we don't prefer cyproheptadine. But in children less than 5 years, that can be a good drug. Sedation and weight gain are the important side effects to be considered when you use cyproheptadine. Typically, we use more in cyclical vomiting rather than migraine.
Another question about vestibular migraine. Shruti, you can please read that.
Yeah, they want to know about the G-punch for vestibular migraine. So could you please elaborate on that?
I have never used them, but calcitone is gene-related peptide.
Yes.
Yeah, I have not used them. I think in children we don't really use them.
It's not approved
Yeah.
for use in
Yeah,
children. There are no
exactly.
studies or trials in children, and it's very expensive also. So, I don't have any personal experience with use of GPANTs in children, but the data in adults says that it's a good drug, and they say that it's not more effective than other drug, but when patients do not respond to other drugs, then this can be an option. Actually, it's not better than other drugs, but when other drugs fail, the last resort you can use GPANTs.
All right. Sure, sir. I think we've pretty much covered all the questions. Ma'am, I think we've covered most. We've not missed out on any.
Yeah. Any
Thank
other
you.
questions from the audience? Okay. Dr. Mahesh, the question about cyproheptadine, how long do you use it in cyclic vomiting?
Whenever we use any preventative medications, we usually use for about 3 to 6 months. And we expect at least 50% response should be there after using the preventive medications. And if there is more than 50% reduction in the headache after using preventive medication for more than 3 to 6 months, then we tend to taper the preventive medication. This includes drugs like topiramate, amitriptyline, cyproheptadine, anti-propranolol. Used for about 3 to 6 months.
Flunarizine is another common drug which we use.
Used for 3 to 6 months, and then after 6 months, if the headaches are reduced by more than 50%, then we tend to taper and stop. But again, assure that lifestyle modifications are continued in the treatment. CBT is also an important technique for prevention of migraine. So if you have a good psychologist, you can advise CBT. It has been found to be very effective also. And there is a lot of studies say that CBT is a very good preventive strategy for migraine prevention.
All right, sir.
Lifestyle modification in children is the most difficult part.
I understand,
But listen to you at all.
We need to ensure that's actually.
And
It's
the more you
difficult,
tell, more we'll become enemies of them. They will look at us as enemies, and they won't.
That's a practical problem, but that is the effective treatment in primary headaches actually.
All right.
So Jitendra can give his final remarks, and later we can close. Sumita.
Yes.
Yes.
I thought Kushal will speak. Dr. Jitendra, sir, some remarks from you.
Thank you. It's very nice pleasure to listen the great cases and experts' opinion. It's really awesome. Thank you very much. Just want to add that, like Dr. Mahesh has said, it's placebo has the best efficacy. So you should try something in all the children. So over time, what we used to believe, many of the cases, primary migraine, over time we learned that those are somatoform headache because of the lot of the school bullying and etc., which we fail to recognize often. So here the placebo role, and like Dr. Mahesh said, CBT works very well. And second, for pediatricians, many times kids come complaining of the headache when they are playing. So those headaches are taken to be very seriously, because those are mostly organic headaches. So those needs to, because a lot of vascular malformation after playful activity, it increases the blood flow, it increases the transient raised ICP. Those gets ignored, and when they rupture, it presents. So those are the very serious form of headache. They should be promptly investigated. Thank you very much.
Thank you very much, sir. I thank our chief guest, Dr. Jitendra Sahu, for giving his expert opinion. And I thank Dr. Maya Thomas for her expertise. And I thank both the speakers, Dr. Riti, Dr. Mahesh Kamte, and Dr. Ritisha. And I thank our coordinator, Dr. Nandish, and our convener, Dr. Sumita Nayak,